So I'm recording. Here we go. Okay, good morning, everybody. We may as well start. We have a couple of minutes to start, but because I have so many slides, I thought I may as well start early, and if people can catch up as they come in. How are we today? Are you okay? There's so few of you. What happened? Where'd everybody go? Is it because it's Friday? Sorry?
Can we wait for 3 minutes?
We can wait for 3 minutes, yes. While we're waiting, any questions from last time? From the research ethics presentation? Everybody clear? Okay.
We are all ethical now.
You're all ethical now. You're all ethical to begin with. I was serious when I said, I give that presentation all over the world, and every place is very different. India has been the most different. The most different because you answer questions in ways I did not expect. Especially the question around if you don't have all the skills, but you're in an area where nobody else can do it, do you do it? Like give a cesarean. And you all said yes right away. Everyone said yes. Interesting. Everywhere else in the world, they hesitate, but you all said yes. I had to write a paper about that. That's good. Positive thinking, that's good. It's confident thinking. How many of you have an epidemiology background or taken an epidemiology class? Or about demographics class? Okay, so a handful. So a lot of what we cover today will be new to many of you, and for those of you with the right backgrounds, it'll be a little bit of a review and hopefully some new things as well. I'll be curious to see if anybody walks in the last minute. It's like we're in a movie theater. You do have those, really? Yeah. And once again, you'll notice I'm recording this, and the audio will be on my website afterwards. If anybody missed the class, you can share the link with them, and they can listen to my beautiful voice, the pleasure of their own schedule, comfortable at home. 30 seconds. We need more air conditioning in this room. Okay, 10 seconds. 5, 3, 2, 1, 0. Okay, let's start. So the topic today is supposed to be the global burden of disease. And I could have just listed all the important diseases around the world, but that's boring. You can look that up on Wikipedia. Who wants to do that? Nobody wants to do that. Instead, we're going to talk about how we measure those global burdens of disease. Before we do, I will remind you that all of this is on my website. So if you go to, again, deonandan.com, click on academia, and scroll down to IITGN, you can access all the slides and the recording. So if you haven't written that down yet, please feel free to do so. As well, a reminder that my 2 books are free starting today. Now, if you haven't, again, I hope this works in India. It may not. If it doesn't work in India, I will find a PDF to share with everybody. But if it does work, go to the Amazon site, and you should be able to download for free onto any Kindle device. If you don't have a Kindle device, on any smartphone, you can download a free Kindle app, or a tablet. You can download a free Kindle app. It'll work as well. If you don't have a smartphone or a tablet, there's a free web browser you can use. I think it's reader.amazon.com. All the instructions are on the Amazon site. And if you don't have any of that, I will find a PDF for you sometime next week. So hopefully you can access those books. Okay, let's begin. This is the nation of Deonandia. And this is the king of Deonandia, a very handsome man with his crown. Deonandia is at the center of the world. It's a low-income country at the center of the world. But it has very limited budget. We know in Deonandia there are 3 important diseases: cooties, malaria, and diabetes. Forget anything you seem to know about those. I just made up some words, okay? You are all the ministers of health for Deonandia, and I am the king of Deonandia. And I need advice from our ministers of health about which of these diseases I should spend my money on this year. I can afford to only invest in one disease. What information do I need to make that decision? As ministers of health, tell me, what information do I need? Put a hand up. Any ideas? Yes.
Deaths per year.
Deaths per year, mortality rate. Okay. What else do I need to know? Causes? Okay, that's very good. Anything else?
Manpower.
I'm sorry?
Manpower for tackle that problem.
Okay, that's very good. And one more?
The last 10 years.
Prevalence of the last 10 years. All right, very good. And one more.
Preventions and medicines which we already have.
You guys are way ahead of me. Excellent. But everyone I spoke to around the world, the first thing they say is deaths per year, mortality rate, which is good. Now, all of those are examples of indicators. You've already seen indicators. You've probably used indicators in your classes already. Indicators are just a number. We can have some strange definition like this, a prediction, proportion, condition, whatever it might be. But in global health and development, there are careers built on indicator development and selection. It's just a number. An indicator is. So why do we have indicators in population health? We use them to monitor which diseases are affecting a population. We use them to see whether or not our programs are succeeding. And if there's time, we'll talk a little bit about the MDGs and the SDGs and the indicators that go into measuring their impact. And lastly, to inform decision making. I just asked you to give me some indicators so I can choose which disease to invest in. That's an example of decision making. So here are some stats from this artificial country of Dionandia. So cooties said 8% of all fatalities, malaria 2%, diabetes 0.1%. Based on these data, which is the most serious disease? Forget this part. Which is the most serious disease here? The first one, 8% of all fatalities, based upon deaths per year. However, now we have a new disease. It's called old person disease. Just showed up this past year. Old person disease accounts for 10% of all the fatalities. That's more than 8. So is old person disease the most important disease now? Oh, you guys are way ahead of me. Absolutely. Now, it's 100% fatal to old people over 65. It's only 1% fatal to those under 65. Is it now the most important disease? You mentioned already, it depends on the number of old people. Maybe. The other factor here is that how much do you value your old people? Many societies will say that all that's really important is the young population that is economically active. So if something is really fatal to that proportion of society that is not as valuable, we don't rank it as highly. I'm not saying that's true. I'm saying that's one way to make the decision. 65 in many countries is a year of retirement. So after that point, you're not economically active. So suddenly we've injected values into these numbers. It's no longer about which number is biggest, it's about which numbers you value more. So we have to be aware when we choose our indicators of, are the numbers telling us what we think, what we value, what we expect, and so forth. There's always a human portion to all of this. Okay, so which indicator you select will depend on what you're trying to measure. You're trying to measure how many people are dying, how many are suffering, what does it cost, which is the fastest growing, which proportion does it affect, all those things. So we have to decide beforehand, what is it that you care about? So when you see lists of numbers on these documents produced by the WHO or by the Minister of Health, think about the values, the agendas that went into deciding which ones to collect. So here's some of the boring academic aspects of indicator use. Indicators hopefully meet at least 4 criteria. The first one is definition. Is it well defined? For example, I can say, I care about measuring happiness. All right? So what is the level of happiness in this room? How do I measure that? I have no idea. How do I define happiness? Do I ask you how happy you are on a scale of 1 to 10? Do I measure your blood pressure when exposed to various stimuli? Do I measure your cortisol levels? Do I look at how many you're smiling? I don't know. Is it valid? Let's say I decide to measure happiness in this room. I count the number of you who are smiling. I see, 40% of you are smiling. Therefore, there's 40% happiness in this room. Is it possible to be happy and not smile? Yeah. Is it possible to smile and not be happy? Yes, it is. So smiling is not a valid estimator of happiness. That's not valid. Feasible. If I'm going to measure happiness for the entire country of India, am I going to count how many people out of a billion are smiling? That's not logistically possible. That's not a feasible indicator. And lastly, utility. Is it useful? Is it useful for me to measure how many people are smiling? No. That's not useful at all. No one's ever going to fund that project. So these are important. These are at least 4 definitions or criteria we use when deciding if an indicator is viable. There are 5 categories of indicators. I don't spend too much time on this because I have so many slides to go through. But the first is health status. That's the obvious one. An example of this is, do I have examples on the next slide? I do. Prevalence of breast cancer. By the way, these links here, these are links to the Canadian government definitions of these things. I use the Canadian government because I know that well. I should have taken some time and found some Indian examples too, and maybe I will in the future. But prevalence rate of breast cancer, that's a health status indicator. Non-medical, smoking rate, that's an example. Or maybe the rate of people who walk every day versus driving every day. Those are non-medical determinants of health. Health system performance. How long must you wait for surgery? How far is a local doctor? How many doctors are there in your area? Those are measurements of health system. Community health system characteristics. These are things that are non-medical but may be related to medicine, like population density, or proportion of old people, or proportion of disabled people. And lastly, equity. That's a difficult one. I don't want to spend too much time on this because I don't really understand it either. But equity talks about if the people who are poor were not poor, would they be as affected? Right? So it's a difficult concept. I'm going to skip over it because I know it's confusing. We don't want to spend too much time on that one. So among the famous indicators that we look at, I'm going to go over some of the basic ones here. Mortality is the obvious one. Now, gentlemen here mentioned deaths per year. That's the crude death rate. So mortality is the number of people who die divided by the total number of people who are at risk for dying. Who's at risk for dying? Everyone who's alive at risk for dying. If you're alive, you're at risk for dying, right? So usually we give it as a percentage or as a rate per 100,000. For example, in 2000, the malaria mortality rate in Djibouti was 119 people per 100,000. That's easily understood. But we can break down mortality rate in many ways. Before we do, let's look at, here are the trends globally and project into the future for mortality rates. Look at these top 3, cancers, ischemic heart disease, and stroke, and these bottom 5, minus this one. This is road traffic accidents. Do you see a trend here? What's different between this group and that group? These are going up, these are going down, but how are they different in terms of diseases? These are chronic and these are infectious, more or less. So we think that there's going to be an increase in the mortality rates of chronic diseases and a decrease in the mortality rates of infectious diseases. With the exception here, this is not infectious, this is road accidents. And India, by the way, is the world capital of road accidents. So this is going to be a big one to watch in the future. So mortality rates, we can break down mortality rates in hundreds of different ways. And I'm just going to look at 2 of them. The first one is the case fatality rate, the CFR. The case fatality rate is simply, if you get the disease, how likely is it you're going to die of the disease? And we think that the most lethal disease in the world that we know of is Ebola, probably. Right? Up until this past year, the case fatality rate was over 90%. This past year, it went down to about 70%. Why did it go down? How does the case fatality rate go down? Sorry? Who said that? Yes?
Better medical care?
Better medical care, absolutely. Better medical care, yes.
Also, I would like to add that Ebola has a higher CFR. That completely depends on where you are when
Yes, absolutely. True. So we can break this down by geography, by the demographics of who gets it, and so forth. The CFR for men is different from that of women. CFR for Liberians is different from that of Americans. You know? So you're right, all these other factors are rolled into these indicators, which is why you should never take these things at face value. Examine them more closely. So CFR will change over time and over geography. Don't look at it as an absolute. As opposed to the proportional mortality rate, the PMR, which is amongst everybody who died, what proportion of those deaths are accounted for by this particular disease. So in sub-Saharan Africa, the PMR from cardiovascular disease is 10% of all deaths, and of coronary heart disease, 3% of all deaths. It's different from the CFR. The example I gave you in the first couple slides of cooties, malaria, and diabetes in this fake country, I looked at PMR and CFR. CFR scares people. The media is really big on reporting CFR deaths. But I tell my students, for example, Ebola, 90% CFR. Should you be afraid of Ebola? No, because you're never going to get it. In Canada, probably never in India also. A handful of people in parts of Africa are going to get Ebola and nobody else. So you should not be afraid of Ebola where you live. So these are the examples I showed earlier, same numbers. So when you choose an indicator, you should ask yourself, what is it you are trying to measure? How many people are dying? How many people are affected? How do you define affected? Is it economically? Is it suffering-wise? Is it emotional? Was it costing? What does it cost if I don't address it? All these other factors. And so like I said, there are careers built on indicator development and selection. And if you're looking for a way to drive your career, this is not a bad way to go. So the next one we're going to look at, I'm sorry I'm going so fast because there's so much to cover. And I can cover this again next time I see you. Poverty line. We're always big on talking about poverty, but there are actually many different ways to measure impoverishedness. The standard WHO definition or World Bank definition, I think now it's if you live on at least $1.25 a day, you're not impoverished. I think that's their economic definition. But we have a poverty line per country, and every country defines it differently. So if we say that 10% of the population of the USA lives beneath the poverty line, and 8% of the population of Bolivia lives beneath the poverty line, is it safe to say that the USA is a poorer country than Bolivia? No, obviously not. The difference is that those countries define poverty differently. And we'll see how in a second. So one standard definition is the minimum level of income deemed necessary to achieve an adequate standard of living. What's a standard of living? Well, that's the essential resources of life. Food, shelter, maybe medicine, not education, not childcare, just the essentials to keep you alive. And it's going to vary between countries over time. And sometimes we compute it relative to an internal standard. And I'll show you what that looks like in a second. But one thing to consider is we're looking at the essentials of life. In most countries, meaning most low-income countries, what is the biggest cost that you are likely to encounter? Throughout your entire lives, the one thing that will cost you the most money is what? Sorry? Let's see a hand. Is it food? Is it medicine? Is it your vehicle? Is it gas? What is it? Your house, rent, shelter. Right? Rent or shelter, your house will always eat up the most amount of money that you have. And if you're a high income, the biggest thing you'll ever spend money on is your mortgage. Now, think about what that means. It means every time there's property speculation around the world, people in the stock market buying up property in such a way to leverage and increase the price of real estate, that has dramatic effects on poverty levels, because suddenly that pushes up the price of the essentials of life. Now, there are different ways of computing poverty, like I said. This is the way Canada does it. We have something called the LICO, or the Low Income Cutoff. And it looks like this. We look at how big your community is and how many people live in your house. Those two factors combined, we devise a cutoff saying you must make at least this much money to not be impoverished. So in Canada, if you have a family of 3, and your population is 100,000 to 500,000, you must make at least $27,000 per year to not be considered impoverished. That's the way we do it. But there are many different ways. Here's an article from The Hindu in 2010 that talks about a multidimensional poverty index that's being computed. We're always working on new methods of computing poverty. I'm not sure this is completed yet. They're still working on it. But if this interests you, you can Google MPI and see what kind of work has gone into measuring poverty. When we talk about poverty, there's relative versus absolute poverty. Relative poverty means, are you impoverished beneath some measurement within your population? Absolute poverty is, are you impoverished beneath some external standard that we can define? So here's an example. In the European Union, they say you're impoverished if your income is less than 60% of the median income. Okay, think about what that means for a second. Consider a country like Brunei or Saudi Arabia, where everyone's kind of rich. It's possible to have a society of millionaires, but by this definition, somebody has to be impoverished, even if you're a millionaire, because someone is going to make less than 60% of the median. Okay? So beware of these relative measures. Just because you're impoverished according to a relative measure doesn't mean you're actually suffering. Absolute poverty, on the other hand, talks about the actual essentials of life. Now, sometimes we say absolute poverty, we mean extreme poverty. What we actually mean in this case is some kind of absence of income necessary to bring you the necessities of life. And here's this definition here, a condition characterized by severe deprivation, etc., etc., etc. But how do I make this useful? Remember I said that among the criteria for a good indicator, we care about feasibility, usefulness. How do I make this useful? There's no obvious way, but somebody tried. Somebody tried. And here's an example of somebody trying. You can look this up in the UN website of someone trying to have a definition of absolute poverty. And what they said is, of these 8 criteria, if any 2 apply to you, then we will define you as being absolutely impoverished. Things like, do you have enough food? And you define food as body mass index, which is a bad way of doing it, a very invalid measure. The second, do you have safe drinking water? And they say, must you walk more than 15 minutes to get water? Do you have toilets? Do you have access to healthcare, whatever access might mean? Do you have shelter? And by shelter, do you have a home with a roof with fewer than 5 people? Do you have at least primary education? Do you have access to information? This is a new thing, right? So do you have access to a newspaper? Some people now will add the internet as being a necessary condition. And lastly, access to services, whatever services are. Maybe it's services to fix your plumbing or to, I don't know, I have no idea what services means. But I'm not saying this is the way to go, but here's one person's attempt to operationalize a definition of absolute poverty. Final thoughts on poverty. There are lots of ways of defining poverty, and there's no consistency between the different ways. So beware of when people are comparing 2 different countries' poverty states. Ask yourself how poverty was computed in both cases. Okay, prevalence and incidence. I know the epidemiologists and demographers know the difference, but it's amazing how many lay people don't know the difference. What's the difference between prevalence and incidence? Who can give me a definition of difference? Sorry? Well, they both can be issued as percentages, but... Sorry?
Prevalence is not a rate, it's a ratio. Incidence is a rate.
That is true, but another key difference between the 2 is?
Incidence is the number of new cases.
Exactly right. Everything you said is true, but that's the critical difference there. Prevalence is the proportion of cases right now. Okay, and usually we give it as a percent. And he's right. It's not a rate. It's a ratio. Technically, a rate is something divided by time. Doesn't matter. That's a technicality. Here's an example of prevalence. In Panama in 1995, the prevalence of HIV was 0.9% of the adult population. So it matters what, among whom, where, and when, right now, or at least in a time frame that's given. Whereas incidence is new cases. It's critically different. Okay? And this is a rate, meaning we divide by time. So in Uganda, the incidence of HIV among adults fell from 7.6 to 3.2. Now, think about this number for a second. The incidence of HIV fell from 7.6 in 1990 to 3.2 in 1998. Does that mean that the situation in Uganda is getting better? Why not? You shake your head. Sorry, is that what you're saying? Yeah?
New cases are becoming what the previous cases might not.
Exactly right. So just because the new cases are slowing down, the old cases are still there. So the burden of disease is still there. In fact, it's getting greater because there's still new cases being added. It's just getting worse slower. It's a critical difference. Look at this. I love this graph. I show this graph any chance I can get. This is the new cases of AIDS HIV in different regions. So in Latin America, from 1990 to 2000, it was kind of steady state. In North America, it declined dramatically in the early 90s or mid 90s. Do you know why it declined? It's because we introduced the new drug cocktails and public education. So the drug cocktails prevented HIV from converting to AIDS in the 90s, and so the rate dropped dramatically. Now look at the Caribbean. It went up dramatically. What happened in the 90s to cause the Caribbean case to increase so much? Any ideas?
Drug resistance.
Good guess. It's not drug resistance. It's too early for drug resistance. Any ideas? It's a tricky one. It's something we call... No, back there? Is that what you said? No, that's not the case. It's actually a case of we call detection bias. So what happened was, in the early 90s, we started investing in HIV surveillance in the Caribbean. It was always high. We just started finding the cases over here. Okay? So we have to be wary. When we look at data like this, is it actual trend going upwards, or is it simply because we're looking for things, we find them more? And I'll give you a practical example of that. So I was once consulting on a HIV project in a certain country in South America, and the implementation plan was such that we're investing in treating HIV and AIDS and in building new labs for people to be tested. And we needed an outcome indicator, again, to measure whether or not the plan would work. And the plan said in 10 years, we would have a lower rate of HIV and AIDS in the country as a result of all our efforts. And I said, no, you have to take that out. Why did I say, no, you have to take that out? Remember, the intervention is we're going to build labs to test for HIV, and we're going to make programs to treat HIV. If our outcome of success is fewer cases, why is that wrong? Do you see it? It's very subtle. And senior government bigwigs didn't see it. So it's a case of detection bias again. If our plan is to look for more cases, we're going to find more cases. And if our measurement of success is fewer cases, we're going to look like we're failing. Because of course we're going to find more cases. Because that's the game. That's the entire project, is to look for more cases. So choosing an indicator is critical in that it must be matched to the outcome and nature of your project, or else you're going to set yourself up for failure. In that case, the best outcome would have been we're going to find more cases, or look at output indicators rather than outcome indicators. We can go into what that means later, because there's a subtle difference there. Okay, moving on. Sorry, I'm going really fast, aren't I? I want to cover a lot of things in 1 hour. So child health, and another important indicator of population health. There are various measurements of child health, various categories. First is neonatal. Neonatal means newborn, the first 28 days of life. Second is perinatal. That's around the first month or before and after birth rather. Infant mortality. An infant is someone under 1 year of life. Infant mortality is a critical indicator. Why is infant mortality a critical indicator of health, of population health?
Infants are more susceptible to small changes in healthcare and health environment.
That's right. Now, do you know that many societies around the world don't even name their children until they're 1 year old? Or you have special one birthday ceremonies. Because historically, if you're going to die before you're 1. And so you don't let it get attached to your child too much until it's 1 year old. Then you feel safe to name it, and then you can go forth and so forth. So we measure the rate of death before 1 year old, because that's, if you pass that critical gate, then we know you're probably okay. Child is somebody under 5. We also measure child mortality rates, because if you live past 1, you will probably have a hard time until you're 5. If you're going to die before you're 1. If you live past that and you're going to die before you're 5. Those are the rules of the game. So as a result, one of the MDGs, the Millennium Development Goals, which I assume you all know about, is that we're going to invest in reducing child mortality rate. So what are the biggest killers of children? You probably know this. Here they are, right? And this is data from like 10 years ago, but it hasn't changed really. There's something really special about this list. What do all these diseases have in common? Do you see it? They have 2 things in common.
These are all communicable.
They are communicable diseases. That's the first thing they have in common. Yes. The second thing is
Also, it's linked with the previous, the pregnancy period.
they're around pregnancy. Yes, we can make investments around the pregnancy period to prevent these. But that's the kick. They're all preventable. Absolutely. Right? So 30,000 children die every day of preventable diseases. We know how to prevent all of these. So there's no reason that we can't eliminate them. That's why child mortality rate is an accessible Millennium Development Goal. It doesn't require any great technological innovation, doesn't require a lot of money even. Diarrhea, soap and hand washing. Not a lot of money required for that. HIV, sex education, that's all it takes. Measles, we have a vaccine for that. This, well, that's a little harder. That requires a little more medical intervention. But as we can see, that's why we focus on child mortality rates as one of the primary MDGs. We can do something dramatically good around this area. And have we done that? Let's find out. Sorry, same slide again for some reason. Okay, we have, because from 1990 to 2011, we've gone from 53 per 1,000 live births for boys to 89, to 89 to 53 rather. So we have an enormous improvement in the last, how many years is that? 20 years. That's global, absolutely. Obviously there's some geographical heterogeneity here. But some things are getting much better around the world. In fact, many things are getting better around the world. And many people would argue that investments made in the wake of the MDGs have proven to be somewhat successful. Still, there are problems. So this graph shows us where the problems lie where it comes to child mortality rate. The more red areas are the worst. So unsurprising, Sub-Saharan Africa is the worst. You'll find this over and over again, the same story. Where it comes to these primary indicators, Sub-Saharan Africa will always show the worst. India, not that great. India's not doing great, but it's better than Sub-Saharan Africa. India, though, it's gone down dramatically. This is from 1970 to present day. Our infant mortality rate is less than 1 year, has come down dramatically. Why do you think that is? Any ideas? I'm sorry?
Home-based newborn care.
All kinds of programs of investment like home-based newborn care, absolutely. Now that requires money. And one could make a hand-waving argument that has a lot to do with India's increasing wealth. So this is your GDP increasing from 1950 to present day. Look at that, incredible acceleration of wealth. So that's a correlation, it's not a causation, but you know, you can make a strong case that with wealth comes hopefully investments in the important aspects of healthcare. Okay? So related to the child mortality rate and infant mortality rate is the maternal mortality ratio. So those three, the IMR, the CMR, the MMR, are in many people's opinions the most important indicators of overall population health. Any idea why? Think about it for a second. I'll ask you again when we finish discussing MMR. MMR is also called the obstetrical death rate, and it is the proportion of women who give birth who die around the time of childbirth. Now we assume they're dying because of something related to childbirth, usually an infection or something like that. Right? The thing is that almost all of these deaths occur in low-income countries. Almost none occur in Western countries. That tells us right away it probably has something to do with wealth. So I'll ask you again, why is the IMR, the CMR, the MMR considered to be such important indicators of population health? It has to do with that list of diseases that are the biggest killers of infants. What was the thing they all had in common? They're preventable. So these are all preventable. IMR, CMR, and MMR represent preventable states of existence. There's no reason we can't go from this enormous number in the developing world down to zero that we have in the developed world. It has a lot to do with basic investments. So that's the end. Now, as I said, we assume that the MMR are high because of things like infection rates and things like that. Now, there's some people who argue that it's actually higher in the West than what we say, because we don't consider things like domestic violence. In fact, some people claim that in America, the biggest threat to a woman's life when she is pregnant is her spouse. Isn't that interesting? So the death rate for pregnant women in America is most likely due to her spouse killing her. Interesting, right? So some people argue we should include violence into that mix as well. That will change the stats dramatically. But other than that, the primary reasons that women die around childbirth tend to be poverty. How does poverty enact? Well, distance from care, lack of information about the care they should receive, inadequate care available, and cultural practices, maybe outdated midwife care, that sort of thing, that isn't appropriate. So we can make very basic investments to improve MMR stats, building roads to make it easier to get to healthcare centers, making certain key drugs like misoprostol available. Misoprostol is one of these magical drugs that can treat postpartum hemorrhaging. I won't spend too much time on this graph. This one's better. This shows us the percentage of age-related indirect maternal deaths. And I put a number there. 10 is the highest in this list, and that's actually in wealthy countries. So wealthy countries do well in everything related to MMR except around AIDS deaths. It's interesting, isn't it? Whereas you look at the biggest improvements in maternal mortality rates since the last 20 years or so has been in Eastern Asia. They went down by 6 points there almost. Why is Eastern Asia doing so well? And by Eastern Asia, of course, we mean China. China's doing well, again, because probably of wealth. So the Chinese miracle, economic miracle, happened in the last 20 years, and they have translated that wealth into investments, we think, in general population health care. And we think India is doing the same thing now as well. So where's India here? India, South Asia, not bad. Came down by 5 points here too. So India's doing well there too. Well, doing better than previously. And again, here is a global map of where the worst MMR cases are in the world. Unsurprisingly, it's worst in sub-Saharan Africa. They struggle with almost all the key indicators. If you care about the topic of indicators, you can look up more of them here in the WHO's core indicator database. There are literally hundreds of indicators you can explore, and I've taken some time to explore them. For example, I did a quick study to see if we can use measurements of female empowerment, indicators of female empowerment, to predict certain kinds of political behaviors. So the study that we did was we decided to look at the Arab Spring. Remember the Arab Spring a few years ago? That's when certain Arab countries were having revolutions. So we broke down the Arab countries in 3 groups. Those who had revolted, those who were at risk for revolting, and those who would never revolt. Make it 2 groups, those who had revolted and those who hadn't revolted yet. And we looked at their female indicators. What we found was that this is the mean percent population ratio of women to men, and this is the nations who have revolted, the nations that are currently revolting, and the ones who had not yet revolted. It's almost a straight line. In other words, what we found using free indicator data from WHO was that the more women you had per man in your population, the more likely you were to revolt against the tyranny that oppressed you, according to these very basic data. Now, this is not causal data, this is correlational. But this shows you an example of some of the fun things you can do with free indicator data to try to tell larger stories. We published this a while back, and it made no impact at all in the world. By the way, this is the opposite of what you expect. Usually around the world, the more men you have, the more likely you are to be politically unstable. But in this case, we show the opposite. Okay, a word about numbers. Keep in mind absolute versus relative numbers. Forget that example. I'll give you a better example. In Ontario, in Canada, where I live, Ontario is a very wealthy part of Canada. About 20 years ago, there was a big news story. It said that the rate of cholera in Ontario had doubled in a year. Doubled! Cholera is a serious developing world disease, and here it is in the heart of the wealthy north. Doubled. People were really scared. You know what? It went from 1 case to 2 cases. It had doubled. Okay? So the doubling is the relative measure. The 1 case and 2 cases, that's the absolute measure. Beware of the difference. And you have to use your intellect to be able to tell what measure you need to use to tell the right story. Okay? Now, let's move on to the granddaddy of them all. This is life expectancy. Everyone thinks they understand life expectancy, but I'm pretty sure most people don't. When they say the Western European population is aging, what does that mean, that they have an aging population? Yes, sir?
The percentage of people above certain age, say 50 or 60, is...
That's right. That's exactly right. That is correct. You guys know all this stuff. Most people would say, oh, people are living longer. No, they're not living longer. Lifespan has not changed appreciably in the last 100 years, in my opinion. But the average age has increased. And I'll show you how that looks. Life expectancy is the expected time remaining to live. You know all that stuff. In the lowest around the world is in sub-Saharan Africa. In Swaziland, it's 50 years at birth. In Japan, it's the highest, it's 84 years at birth, and so forth. Here, look at these data from the US. This tells the story entirely. 1850 to around the present day. Okay? In 1850, at birth, if you're born, you could expect to live to 40. Today, at birth, you could expect to live about 70-something. 1850, if you're 40 years old, you can expect to live to 70. Today, if you're 40 years old, you can expect to live about 75. 1850, if you're 70, you can expect to live to 80. Today, if you're 70, you can expect to live to 80. In other words, the older you are, the older you're going to get, and it hasn't changed over time. All of the gains that we have gained in life expectancy in the USA in the last 150 years have been at birth. Meaning, it's because of infant mortality rate decline that life expectancy has increased. We're not living longer as individuals. More children are surviving childbirth. That's all it means. Okay? So in Swaziland, they have a low life expectancy, probably because a great number of their children are dying young. In the West, I'm not sure about here, but in the West, life expectancy increases as you get older, because as you get older, you bypass the pitfalls of life, and the older you get, the more likely you are to get older. Isn't that strange? Until you turn 16. You turn 16, suddenly you're likely to die younger again. What happens at 16, do you think? Something magical happens at 16 in North America and Europe. I'm not sure about here. Do you know it? No? Sorry?
Hormonal changes.
One more time.
Hormonal changes.
Which is,
Puberty.
yeah, okay. I think we're on the same track here. At 16, that's when most teenagers start to drive. So automobiles is what kills you. So if you survive those first couple of years of driving, then you're back on track again to get older. In the USA, black men do horribly. Black men die at a higher rate than anybody else until they hit 60. Then they do great. So old age homes in the US are populated by black men and white women, because black men do horribly until they get older, then they live forever. So again, what matters here is what happens when you're very young. That's why we invest so heavily in infant and child care, to avoid the pitfalls of early life. This is the world life expectancy from 1950 to today. It's been increasing because the world over, we showed you the infant mortality rates. We're doing better around infant mortality, so world life expectancy has been increasing. This shows us some key countries that have experienced economic revival in the last few years. India is, where's India? India's here. India's going up. China's going up as well. They're all going up except the blue one. Where's the blue one? That's Thailand. It's kind of struggling. But in general, all these economic tigers are doing well. India is doing very well. But we're kind of leveling off near the end here. And you can break this down further. This is different states in India. This is the Indian average. The best state in India is Kerala, for a variety of reasons we can talk about later. And Andhra Pradesh is probably the worst state, but it's improving as well. Remember, life expectancy does not distinguish how or why people died. Life expectancy in Afghanistan is horribly low because of the war. They're dying of war, right? Life expectancy in Swaziland is low because of disease. So the reasons for dying aren't distinguished. And it's the average experience of the previous generation. So it doesn't necessarily say how you are going to live, just how the previous generation experienced life. Okay? So the problem with using life expectancy as a gauge of population health is that just because you live longer doesn't mean you live healthy, right? And just because you live longer doesn't mean you are contributing economically. So from a state perspective, we care about, very often, the money you're producing, the vibrancy that you contribute to the economy. So long life isn't necessarily a plus. However, almost every population health analysis you see will use life expectancy as the indicator outcome that is desired. It's problematic. Let's take a look at age pyramids for a second. You've seen age pyramids before? Age pyramids are very useful. So this age pyramid shows us what bulk of population lives in various ages. So this is Canada. Canada, most of our population is old. See, this is young, this is old. The majority of us are middle-aged, if not older. We're an old society. Let's look at the UK. Is UK old or young? What do you think? Oh, there it is. UK, very old. So not as old as Canada, strangely enough. So the bulk of the UK is middle-aged, but maybe 10 years younger than Canada. Let's look at China. China, old or young? China's young, huh? Let's see. China is like the UK. It's middle-aged, bulk around the middle. So China has the same problems that Western Europe faces. Japan, old or young? Very old. The oldest country in the world, probably. So there it is. Their bulk is around 70, 65. And they're heading for some big trouble soon. India, old or young? Young, there it is. India, probably the youngest. Look at that. So it's a straight pyramid. Everyone here is young. Almost nobody is old. And this has important ramifications for economic growth, population growth, and so forth around the world. In fact, many people think that India will provide the workforce for the world in the next 20 years because of this. All right, so we can have a large conversation about what this means. This is fascinating. China, as the economic giant of the world, of the Eastern world, resembles Europe and North America, meaning they're heading for what we call a demographic cliff. There may not be enough Chinese people to pay for the next generation, whereas you guys have more than enough to pay for the next generation. All right, moving on. We have 20 minutes left. Good. So the next two indicators sound similar, but they're quite distinct. QALYs and DALYs. A QALY is a quality-adjusted life year. Some people call them KALYs or CALYs or whatever. I call them QALYs. Now, there's a difference between QALYs and DALYs. DALYs are bad, QALYs are good. DALYs describe a population, QALYs typically describe the experience of an individual. So I won't spend too much time on QALYs, except to say a QALY tells us how many of the years you have after an intervention are good years. For example, let's say you're going to die of some disease of some kind. But if you have a surgery, you will live another 10 years, right? So great, this surgery will give me 10 more years of life. Are they good years of life? Maybe the surgery will leave you crippled and you won't be able to walk and you won't be able to play ball with your kid or chase your dog or whatever. So maybe those are not good 10 years. How do we measure the goodness of those 10 years? Well, a committee gets together and from a scale of 0 to 1 says, as a result of not walking, each one of your years is worth 0.7 of a regular person's years. So we say that we take those 10 years you're going to live, multiply by 0.7, and you get 7 quality-adjusted life years. Why do we do this? Because it allows us to make decisions about whether or not to have the surgery. Okay? So if you're going to die versus getting 7 QALYs, well, the choice is obvious. You take the surgery and take the 7 QALYs. Maybe if you didn't take the surgery, you will live 20 years with pain, and that pain gives you 0.6 QALYs. So using that method, we can use it for deciding whether or not to intervene at various points. I don't spend too much time with QALYs because DALYs are way more important. Who's heard of DALYs before? Good, only 2 of you. All right. DALYs have changed the way we think about population health. DALYs are transformative. So a DALY is a disability-adjusted life year. And, you okay?
Yes.
Oh, sorry. Oh, good, we have more time. Oh, fantastic. So I thought we only had an hour. I've got a little over an hour, so we have some time to play with here. So a disability-adjusted life year takes into consideration whether or not you die. So before we had DALYs, we measure the severity of a disease based on whether or not it killed you. But lots of things don't kill you that are really bad. Give me an example of something that doesn't kill you that's really bad. Diabetes doesn't kill you necessarily, but it's pretty bad. It makes you miserable. It makes you unhappy.
Paralysis.
Paralysis, absolutely. Lots of things in the world don't kill you, but make you unhappy. So sorry? Bronchitis, asthma. Yeah, I suffer from that. It's bad. It doesn't make you happy. So we needed a way to measure that. So what we have the DALY is a combination of 2 things. The years of life lost and the years of life spent disabled, whatever disabled means. So some things kill you or make you disabled. Like diabetes, you can die of diabetes, or you can live a number of years unhappy with diabetes. So a daily combines the two of them. There's a similar thing called the DALE, which is the disability adjusted life expectancy. That's like life expectancy, except we subtract some years to account for how many years were spent disabled. We're not talking about that, we're talking about the daily. The thing about the daily is that it allows one particular class of disease to enter the conversation. And this class of disease transforms how we think about population health. Before the daily, all we ever talked about was, infectious diseases and diabetes and cancers and things like that. Suddenly, because we can talk about things that don't kill you, a particular class of disease dominates the conversation. By 2020, we think the second most costly disease in terms of dailies is going to be what? Who knows?
Cardiovascular.
No, not cardiovascular disease. Cardiovascular is number one. What's number two, though?
Depression.
Well, look at you. You're so good. It's depression. Right. Unipolar depression. So mental health has entered the conversation. It wasn't there before. And the daily allows us to do that. So this is a graph shows us where in the world most dailies come from. Unsurprisingly, Africa has got the most dailies. The dark represents how many people die, and this part represents disability. So still, death is a major component, but where's India's not really here. Southeast Asia, sort of. Well, but there it is. So this is the distribution of mortality versus dailies. So here, the things that communicable disease represents the biggest chunk of things that kill you. Here, communicable disease also is the biggest chunk of things that make you unhappy or miserable. That's a bad graph. That doesn't tell the story quite as well as I'd hoped. But remember that it brings in mental health issues. And we think that 5 of the 10 leading causes of disability are in fact psychiatric causes. Right? So there's a big push globally to destigmatize both people who have psychiatric diseases and researchers who focus on psychiatric diseases. Because even though we all know this is important, there still isn't a lot of money put into researching it. That's going to change soon. Right. So this is India. This is our 2004 list of the most prominent sources of dailies. It hasn't changed much in 10 years. It's still psychiatric conditions, with depression being the most obvious one. Is that amazing? In India, it's not diabetes, it's not cardiovascular disease. That's down here.
Sir,
Yes?
how do you interpret that 3 to 2 8
That's the number of years of disability per year. How do I say this? It's the number of years of life lost plus the number of years of life spent disabled caused by this disease.
How many?
We're not sure about people, but this number of years. We can't compute people from that. So about 3,000 years of that disease. So it's number of people multiplied by the number of years they have it, plus the number of years they're disabled. So,
For example, say 2 countries,
yeah.
there is quite significant difference between population,
Yeah.
but both have the same 3 to 2
Yeah,
8.
you can't compare 2 countries like that. You can compare the ranking, but not the numbers. Good question, though. That's very good, very insightful. So this is, again, the same conversation, but we're ranking causes of mortality and causes of dailies over here. So this is 2004, both cases, global now. Heart disease, cerebrovascular disease, all these infections are the biggest killers. But over here, infections at the top, depression makes number 3, HIV makes number 5, because HIV actually causes a lot of suffering. So suddenly it changes the conversation somewhat, but not a lot. Look at that, road traffics are still number 9. Right? We think in the next 20 years or so, these are the shifts that are going to happen. So this is 2004. This is what you project for 2030. So right now, lower respiratory infections are the biggest causes of dailies. We think that will be number 6 in 15 years. Number 1 is going to be depression. Depression right now is number 3. So these are the projections that they're making right now. It could be wrong. This is based on some regression models that are done by the WHO. That could be wrong. Right? But this is stuff that's happening right now behind the scenes. Again, if you're looking for a career, modeling the future of disease impact is a fun career to invest in. So let's talk briefly about the Millennium Development Goals. Who knows what they are? Who's heard of them before? Okay, you haven't heard, no, you haven't heard of them before. The MDGs were put forth at a conference before the turn of the century. And the idea was to define 8 things that the world should focus on to change development status for the good in the next 15, 20 years. And they landed on 8 items. The first was eradicate poverty and hunger. Second was achieve universal education. Third was promote gender equality. Fourth was child mortality. Fifth was maternal health. Sixth was HIV. Seventh was environmental sustainability. Eighth was global partnership, whatever that means. So from that point on, almost all of the major global investments in health and development were tied in some way to these goals, MDGs, Millennium Development Goals. And if you wanted to show that your intervention was worth funding, you had to show how it was linked to one of these goals. There's a lot of criticism about this, though. So remember, one of the directives of the MDGs was that we must achieve success in these areas by, I think it was 2012 or 2015 was the outcome date, right? What do you need to know in order to achieve success in these things? You gotta be able to measure these things, right? So to measure them, what do you need? I'm sorry? Oh, perfect. Baseline data, exactly right. Baseline data and indicators. You have to define indicators for each of these. So for this one, maternal health, what indicator would you use? MMR is the obvious one. Do we have baseline data for Chad? We don't. So how can we say that improvements were made? We can't say that. How about environmental sustainability? What's an indicator we could use for that? CO2 conditions, sure, that's possible. Proportionate renewability, absolutely. Very good answers. They don't really exist yet, those indicators. We can talk about them, but no one's collecting that data regularly. Let's look at gender equality. How can we measure gender equality? Sex ratio is one of them. What else? I'm sorry? Okay, yes. Anything else? Education levels, very good. There's a whole list of wonderful gender empowerment indicators they developed specifically for the MDGs. Among them is proportion of women in parliament, the age at first marriage, the assumption being older shows more equality. I'm not sure what the logic behind that is. There's also a new composite gender equality index they've developed, right, specifically for this purpose. But again, there's no baseline data in a lot of countries.
So rates of gender-based violence.
Yeah, that's a good one too. Again, how do we collect that data? A lot of countries don't collect it. Right? So we can't say for sure that improvements are being made if we don't have the data to tell that story. Yes, sir?
You also have mysteries that that's due to disasters like terrorism, floods, earthquakes.
That's right. Where would that fit?
There is no, there should be a trend of how over the last 50 years because of environmental.
That's a possibility, yeah.
So even terrorism and political movements.
Yes.
That's absolutely true. And as you can probably see now, those get confounded very quickly by, is that the case, is that a cause of a development intervention, or is that was that caused by a political policy? Is that caused by religiosity? Is that caused by population pressures? Suddenly the analysis gets complicated. That's a very good point. But we don't have the indicators for it. So right now, we are debating the Sustainable Development Goals. Who's heard of those, SDGs? A few of you has, good. So the SDGs are the new set of development goals that will take the place of these goals. And we don't know yet what they will look like. I have a student who is investigating the process by which they're being decided upon. And one of the important components of that discussion that's happening right now is the measurability of those goals. The difference between the SDGs and the MDGs is that the SDGs are supposed to go on forever. The MDGs are supposed to end soon, right? But the SDGs are things that we're supposed to target ad infinitum. And we don't yet have indicators for each of those goals. All right, it's a big problem.
Sir,
Yes, sir.
also for the measuring the child mortality, do we include the stillbirth? There is no indicator.
Do we include stillbirth? Yeah, we include stillbirth.
Stillbirth.
Yeah. Yeah. Not for child, but for infant. We usually include that amongst the neonatal, not the infant mortality, because that's part of the perinatal neonatal experience. Yeah. One last slide here. Okay, so the challenges here are the consistent definition of indicators and how we use them and what they mean and how we select them. Choosing the right indicator to tell the right story. So it depends on the story you're trying to tell. Obvious example, PMR versus CFR. Are we looking at lethality? Are we looking at distribution? Are we looking at economic output? Whatever it might be. Numbers are collected in different ways by different people in different countries in different years. So it's hard to describe. I was going to show you another graph. I forgot to include it. In the USA, in 1955, the diabetes rate, national diabetes rate, dropped dramatically from, I think it was like 25 cases per 1,000 to 15 cases per 1,000 in 1 year. What happened in 1955 in the USA? Nothing happened. What happened was they changed the definition of diabetes. That's all it is, right? Same in sub-Saharan Africa. The AIDS, the rate of AIDS decreased dramatically in the early 90s. Why? Because they changed how they diagnosed AIDS. Before the saliva test, they used what's called the Bangui definition. The Bangui definition is you look at someone, you say, are they skinny? Do they have these lesions on their body? Are they weak? Are they sleeping a lot? There's a whole list of criteria here. Yes?
So once the definitions are changed, the previous data, are they no more removed?
They should be removed, but they're often not removed, right? Because we need something to use, right? So we have to look at that when you look at these data going back in time, you have to be very careful that you're measuring the same thing each time in the same way. And very often, the data that's reported do not do that. So always be critical about the data you see. Most countries, or many countries, don't have the infrastructure to collect these data. I keep using Chad as an example because I know Chad fairly well. So there was a movement a while back to send tens of millions of dollars to Chad to improve their malaria situation. The problem with Chad, though, is they didn't have a banking system. So there was no one there to receive the money. There's no one there to receive it and then to write checks to the NGOs. So what do? You can't give them tens of millions of dollars. So you need an initial investment to set up a financial system that could receive the money. Right? So it's one thing to say, we need to collect these data. Oh, we haven't got people to do this. Oh, we need to spend money now in collecting these data. But now we need a way to actually spread the money around. It gets very complicated very fast. Now, to get the information we need to make decisions like this, very often we have to invest in surveillance. What is surveillance? Who's heard that term before? It's not, the government watching you. It is?
Keeping an eye on the changing trends.
Yes, particularly around diseases. So monitoring which diseases are occurring when. And every government worth its salt is attempting to surveil diseases to the best of their abilities. So in Canada and the USA, there are literally hundreds of surveillance systems running in real time all the time. Everything from looking at the flu, influenza, to measles, to suicide, to depression. We have enormous surveillance systems. Some are small, some are large, some are electronic, some are physical. Some are active, some are passive. Do you know the difference between active and passive surveillance? You do? What's the difference?
So active is, that is, we have the direct data of what we observe. Passive is we are using secondary sources.
Sort of, very close. Passive is when the data comes to you. Active is when you get the data. So if you have to go out and do a survey to find out what proportion of people are depressed, that's active surveillance. Passive surveillance is when you have a system that delivers you the data automatically. For example, in many countries, there's something called a notifiable disease registry. What that is every doctor in the country is under orders. If they see a disease on the special list, they must, by law, call the government and say, I saw one of these. Right? So that's how we know. If an Ebola case pops up in France, they know right away because Ebola is one of the diseases there. The doctor must call. I saw an Ebola case. So in Canada, we have, I think, with about 20 diseases on that list. They include things like measles. They include things like diphtheria or plague, very rare diseases. The reason for this is that certain diseases need instant response. You can't waste any time. Right? So that's why that's a passive system. It comes to you right away, so we know, this will set off an alarm. We send resources to that place and we curtail it. India has a similar system. I'm not sure how it works here, but I know something similar does exist here. As the speaker said on the first day of this conference, the Indian system is not data rich. It's problematic in many ways. Right? What we hope to develop here eventually is a surveillance culture that allows the triggering of epidemiological response so that epidemics can be contained very fast. So I developed a surveillance system for tuberculosis for Guyana, where I was doing some work. And that was very low tech. Our surveillance system involved a form, a piece of paper. We had clinics in the field, and they were all given this form. If a TB patient was detected, they'd fill out the form, rip it in half, and someone would physically take that form to the government office, make copies, send a copy to me, and send a copy back to the clinic. Very low tech. In Sudan, they have a surveillance system that involves little boys running across the sand with pieces of paper. It doesn't have to be high-tech computer stuff. But nowadays, computers are so cheap, infrastructure is so cheap, it can be computerized. So, all the data that you see on the WHO website or the World Bank website usually comes from something resembling a surveillance system. Also be aware, the indicators that you see on those websites are collected in different ways. For example, you can go to, I won't name a country because I don't want to be wrong, that country's list on the website and see, the infant mortality rate is this much. How do we know that? There's no surveillance system in that country. We know because an NGO came one day and they were doing a study on breastfeeding. In the process of their study on breastfeeding, they asked some questions about infant mortality. And their data became the core indicator. It's not very good data, right? And in this country, a different NGO did another study, and they included a question on infant mortality. And that's how we have that data. So beware, the quality of the data that we use to make these global trends may not be good data.
So is that the same for the WHO data as well?
For the, which data?
Is this data collection the same methods for the WHO data as well?
Yeah, it can be. WHO doesn't collect its own data very often. They rely on other parties to report it back. Right. So it's a problem. One of the projects that a colleague and I tried to put together once was to create a global surveillance fund, much like the Global Malaria Fund. And the idea was that countries could dip into this fund to create their own surveillance system, but in exchange, they must make their data public. We didn't get any traction on that idea, but the same model has been used for other things, like the Global Fund in general follows that model. You can use our money to your health concerns, but you must share your data at the end of the day. That's the last slide, I think. I think I'll stop there. Are there any overall questions about what I talked about? I went through really fast, because there's so much to cover. Any lingering issues, questions? I was so clear you understood all that, really? Okay, okay, I'm sure you have some questions afterwards. I think we'll take a break now. How about 10 minutes? 10-minute break? Yes, yes?
The Sustainable Development Goals which you mentioned.
Yep.
What sort of progress is happening on that?
They're going to make their report official this fall. Right? So I think they're going to finalize their entire list this fall. Yeah. I hope there's going to be an opportunity to revise it, because I suspect there are going to be some issues. We all get to see the final list. It'll be a little problematic. Yeah. Okay, so back here at 11:15. Thank you. Oh, is there a question here? Oh yeah, so.
I wanted to ask you about hospital-acquired infections, and do you have, is there any surveillance system to track the hospital-acquired infections?
Yes. Not in this country, but in other countries, yes. We call that, well, they're different. There's often ambulatory databases. So a lot of countries have a system. Do you know what the ICD system is? ICD-9, ICD-10. This is important. ICD stands for International Classification of Disease. And the WHO maintains this list. What it is every possible disease state has a code associated with it. If you show up with a fever, they look down the list, fever, that's 9.76, and they put that in the machine saying this person came in. After you're diagnosed with something else, with malaria, let's say, they find the code for that, and that becomes your outcome code. So these data are on websites around the world for different countries, and you can use that to quickly analyze the prevalence, distribution, incidence of diseases like this. And we can see if you come in with this set of symptoms and you leave with another set, we can assume that the difference represents a hospital-acquired disease. Right? The ICD system is not perfect. I remember I looked at it briefly to look at very unusual codes. They have a code for werewolfism. You know what a werewolf is? It's a mythological creature. That's when a man becomes a monster. There's a code for that. It's called lycanthropy. So it's under schizophrenia. So there's a code for vampirism, becoming a vampire. Seriously. So I'm going to write a paper one day on the strange codes that they use. But to answer your question in a serious way, the ambulatory databases you can access for a lot of countries. It's hard to find data in India. I've been looking for more and more data, but other countries, yeah, it's coming soon in India.
The hospitals, imply that model. If hospital-acquired infection is more in some hospitals, then they will lose the.
Yeah, there's a lot of danger, obviously, for private hospitals. They don't want to publicize the rates of nosocomial infections, they call it. And a lot of, there are no standards in many countries over the requirements for data publishing. Like in Canada, the hospitals are required by law to keep these data and to share them with the central administration. In India, the hospitals I've dealt with, not all of them collect it. The one that I work with most closely in Andhra Pradesh, they're very diligent in collecting this information, but they only share it with me, not with the government. So there's a problem. Obviously, what we're talking about here are political issues. We need legislation to compel hospitals to both collect these data and to share them. That's not here yet, to my knowledge. Okay, 15 minutes, see you soon. 10 minutes rather.